Hello, and welcome to Session 2, Surgical Interventions in Hemorrhagic Stroke, Evidence and Insights. We are privileged to have two presenters in Session 2 today. Our first presenter is Dr. Jefferson Chen. Dr. Chen is the Director of Neurotrauma at the University of California, Irvine. He is a board-certified neurological surgeon and additional certifications in neurocritical care and neuro-oncology. Since 2013, he has led advances in minimally invasive techniques for intracerebral hemorrhage evacuation. As a reminder, full biographies may be found in the lobby under our speaker sessions. Dr. Chen, I will turn it over to you.
All right, thank you. Okay, someone else is sharing right now.
I go ahead and click on the share button, the green button.
Okay.
And then you can pull up your slide deck.
Okay,
there it is starting. Yep, and if you want to put it in full presentation mode.
Okay, all right. Does that look okay?
Very good. You're all set.
All right. Good morning. Thank you for joining us today. I will talk a bit about some of the early clinical trials and some of the background for intracerebral hemorrhages. No disclosures. Okay, so just a quick outline how big the problem is, and I think Dr. Bourgeois talked a little bit about that. Now I'll talk a bit of some of the key clinical trials for neurosurgical treatment, the Stitch 1 and Stitch 2 trial in particular, which were randomized controlled trials, yet they failed to show that there was benefit from surgery. And I think now, in retrospect, and with newer technology and newer knowledge, we realize some of the reasons they failed and some of the things that we can do as we go forward to improve on our outcomes. All right. I think we've discussed this previously, that this is a large problem and that this is one of the most serious of strokes, and because of the blood being inside the brain where it shouldn't be, so it's in the brain itself, and it is toxic and causing inflammation as well as mass effect. So it has high morbidity and mortality. A bit more granularity here. It accounts for up to about 30% of strokes in the Asian population, and we're not sure why that is, whether it's genetics or environmental, but that has been shown over and over again that certain populations are more predisposed to having the intracerebral hemorrhages as opposed to the ischemic type strokes. And once again, the 30-day mortality is 30 to 50%, and 2-year mortality is 60 to 80%. And this doesn't even talk about the morbidity and the associated problems that patients have and the effect on their quality of life. This is a common scenario that we see, a large basal ganglia hemorrhage. Unfortunately, many of these are in the basal ganglia, which is in the center down here in the brain. And what we can see here on this CAT scan is that you can see the hydrocephalus that develops as well as the mass effect. So just having the blood clot there leads to problems initially. Now, this is a typical location, and you can see that there are many eloquent structures around here, including the basal ganglia, the internal capsule, as well as many of the regions here in the temporal lobe. So given this, that this oftentimes are in a bad area and that these frequently increase in size, which I think Dr. Bourgeois talked about, the question is, do you intervene early or not at all? This is a common scenario where you start out here on the left, and then just within an hour or two, they can evolve to this large hemorrhage here with the extreme mass effect and neurological deficits. What can we do surgically? Well, surgically, you can treat the mass effect. You can also treat the hydrocephalus, which are life-threatening entities just in and of themselves. You can decrease the mass effect. You can target the spot sign, which we'll talk a bit more about, that the spot sign oftentimes, and I think Dr. Bourgeois talked about that also, is a sign of some weakened vessel. Rapid correction of intracranial hypertension and avoiding medical complications that happen down the line. This is just a snapshot of our tracking of strokes here at UC Irvine. And what I have here is our experience here with ischemic strokes. And then these are comparable hospitals throughout the country. And you can see that ischemic strokes are present and the numbers have increased. Compare this to aneurysm subarachnoid hemorrhage, which has plateaued and sort of leveled out. Intracerebral hemorrhages, spontaneous intracerebral hemorrhages, have remained fairly stable, and we find that it's been fairly stable even despite the COVID years. Our numbers have been fairly stable, and I think most people have seen that this is an entity that's here and is not going away. So the better we can do to help these patients, the more we can offer them to perhaps help them with their outcomes. Now, I'll talk a little bit about some of the prior trials, because this sort of sets the stage for the treatment of surgical treatment of intracerebral hemorrhages. And we're talking about spontaneous intracerebral hemorrhages. This is the major trial, the Stitch trial, Lancet trial. It was published in Lancet in 2005. And basically what they showed is summarized here, that there was no overall benefit with early surgery compared with initial conservative treatments. When you look at this a bit more closely, I've looked at some of the key points here and some of the perhaps critique of this that maybe can help us to better look at why this did not really reach statistical significance of improvement. The age range was quite high. There was no indication in the paper of how much blood was removed at the time of surgery. Craniotomy was the preferred method, although there were some other methods that were in there. The number of minimally invasive procedures was low, and the timing of surgery was not ideal. Take a look in here. These are some of the tables I took from that article, and we can see that there is a good mix here between the lobar hemorrhages, more superficial hemorrhages, versus the basal ganglia and thalamic hemorrhages. The time between the ictus and the surgery is between 30 hours in the early surgery group and the 60 hours. The initial conservative treatment, these were the crossover patients who failed their initial treatment and then went to surgery. You can see that the majority of these patients had craniotomies, although there were some other methods here which are not clearly defined. Now, this set the stage for the Stitch II trial, where they looked more closely at the superficial or lobar hemorrhages, which they found had a better outcome in their analysis. So they wanted to do a specific study looking at this. And what they found, once again, was that the early surgery for the lobar hemorrhage did not increase the morbidity or mortality. However, the clinical benefit did not reach statistical significance. Once again, looking at this was a multi-center trial, so it was a big trial across many countries and many centers. There was no IVH in this trial. 99% of the patients were craniotomies. Once again, there was no quantitation of exactly how much hemorrhage was removed. Stereotactic guidance was not used in general. Average time to surgery was about 26 hours. When we look here again, you can see the majority of these were craniotomies. And again, once again, the median time from the ictus, that is the time when the patient had their problem, to the time of surgery, was again about 26 hours. This shows the Kaplan-Meier survival curve, where there's some benefit to survival with early surgery. So in 2022, in the American Heart Association guidelines, this is what was said about surgery. And again, this is supratutorial surgery, that decompressive craniectomies were an option in the cases where there was refractory ICP. However, the outcomes were questionable as whether or not there was any improvement. This is a decompressive hemicraniectomy, just to refresh our memories that it is a large invasive procedure where basically you're removing the bone, and you remove the bone and you do a duroplasty, allowing room for the brain to expand out. Whether or not the hemorrhage is removed is at the discretion of the surgeon, and oftentimes that is dictated by how much bleeding there is and how much swelling there is. Also in the guidelines from 2022, the craniotomy for removal of clot was also an option. However, once again, it was indicated that whether or not there was benefit from this as far as neurological and functional outcome was questionable. And again, once again, craniectomy and craniotomies were more life-saving measures than measures designed to improve outcome. Now, recently, in the last over like 10 years or so, we've had much more information about the track or the fiber tracks that are surrounding these hemorrhages, and that has given us more information as to planning and realizing that if you take the shortest pathway to this intracerebral hemorrhage right into the basal ganglia from the side, you're going to go through many eloquent fibers and eloquent structures. And it is very common to get pictures like this here. I think that what we want to be cognizant of is of the fibers that are surrounding this. And this is just a example of the fiber tractography that was in this particular patient. You can see that this patient has a hole up here in the front. This is the approach to this lesion, which is through the frontal area. But even so, there's fibers here that are missing. So you can imagine how if you came from the side, there would be many more fibers missing. So oftentimes the best trajectory is not necessarily the most direct. And I think that's something that we have learned with the advent of many of these newer MRI techniques looking at fiber tracks. Another advent that has helped us to better understand ICH injury, and again, once again, I think this is something that we talked about, that has been talked about, we talked about more, is the whole molecular events that occur. Now, within the first few hours, we have the increased ICP, the hydrocephalus herniation, which we see right there in the emergency room. However, pretty quickly thereafter, the inflammation process starts, cerebral edema starts, and the toxicity of blood products becomes apparent. Here's another schematic demonstrating the cascade of events. So you can see here around this hemorrhage here, which I'm outlining here, you can see the dark zone here, what we call the perihematoma zone. And that area there is a very active zone where there is a great deal of mitochondrial dysfunction, cytotoxic edema, and many type of pro-inflammatory processes ongoing. Now, what we know is that once these processes start, it is very hard to stop them and attenuate them. And that is one of the incentives for going in early. That is to attenuate and slow down or stop the process of the inflammatory process that can lead to tremendous cerebral edema, which in and of itself can lead to many of the problems with disability and brain swelling. So in summary, the benefits of minimally invasive surgeries is you respect the fiber tracks and try to avoid crossing them, and being knowledgeable about the fiber tracks are the ones that are in eloquent regions. Also, by using minimally invasive techniques, you stay within the blood clot so that you remove the clot from within and preserve the surrounding tissues. With the newer technology, these are more readily deployed, and you can get in there much faster than doing a large craniectomy or craniotomy. And also you are able to get in there sooner to attenuate the secondary injury that occurs from many of the blood products. So in conclusion, spontaneous ICH are common problems with significant morbidity and mortality. The mass effect that occurs initially can be treated with surgery, whether it's the hydrocephalus or whether it's the mass effect itself can be readily treated with surgery. and neurosurgical interventions can attenuate the effects of the mass effect. The newer technologies and techniques and our knowledge of the biology surrounding these spontaneous ICHs has helped us to better treat and approach these. And once again, it takes a multi-specialty involvement with neurosurgeons, neurologists, neurocritical care specialists in particular to optimize, as well as our nursing teams, to optimize the neurological outcome with these patients. Multi-specialty team that we have at UC Irvine, and I will stop there.
Thank you so much, Dr. Chen. We really appreciate you laying the foundation for our summit today. We will hold questions until after our second speaker in session 2. So I will circle back with you shortly. So thank you so much.
Thank you.
Our second speaker today is Dr. Tamar Binyamin. Dr. Binyamin, originally from Chicago, completed her neurosurgery residency at UC Davis and a fellowship in neurointerventional and open vascular neurosurgery at UT Southwestern. She is now in her third year of practice and program development at Sutter Eden Medical Center. Again, please note that full speaker biographies are available in the lobby of the Zoom events platform. Welcome, Dr. Binyamin. I will turn it over to you.
So thank you so much for the opportunity to talk about how we got to where we are and our understanding of it. I obviously am early in my career and I have really had an opportunity, especially in neurointervention, of watching some of people that really develop this field and how to do it. And now being able to kind of participate that in the neurosurgery world is impressive, because all of these early studies, whether positive or negative, really taught us quite a bit that you have to crawl before you walk. You have to understand what we're doing, the ramifications and the outcomes, to really understand how to modify them, improve them, and improve our patient care. I know it's been talked about, but I'll briefly touch on some of the challenges of hemorrhagic stroke, what our prior attempts have been, and what we really learned from them that laid that groundwork in order to understand what our positive trial means and how we can improve patient lives and quality of life from that, the infrastructure of what it takes to be able to perform these surgeries and the results, and how we're able to really take this and continue to build on it. And I have no relevant disclosures. So again, hemorrhagic stroke is really a big challenge for us in the neurosciences, because it's only 10% of strokes, but it's 30 to 40% of mortality. There's just incredibly sick patients. And you know, all of us have stood in a room and wanted to do more and not had the tools to be able to do it, because prior to this year, there have been no randomized trials that have shown to improve functional outcomes. What I want to do is get all of my patients back to as functional and as normal lives as they can, and our ability to do that's been limited. We really could save lives, but not really improve neurologic outcomes. And I know this has been touched on, but really this started in the early 2000s with Stitch 1 surgical trial and intracerebral hemorrhage. And, you know, all you have to do is look at the graph here, and it's a big takeaway for what you need to know. This is a very large study. This was a multi-center, multi-country trial, and it tried to look at outcome scales, whether they were good or bad. And you'll see that dichotomization does make a difference in our ability to understand some of these statistics and how it's evolved over time, how we've changed that. And essentially, what this was open surgical craniotomies, maximally invasive, if you want to say, really just if we take the clot out, do we see a difference? And the long and short of it is surgery did not improve outcomes in the big picture. However, when we started to really drill down and look at some of these early surgery versus early conservative treatment, didn't really show a significant difference. However, subgroup analysis found that certain types of hemorrhages, lobar hemorrhages, which you've seen again the difference between those, and I'll go through those in a little bit, superficial hemorrhages, and the intermediate GCS, people that weren't totally normal, can't really make someone who has no deficit better, but weren't the sickest patients that we see. Those might have some benefit. Wasn't statistically significant, but really kind of trended to. So what that said is what we could do by just going in and maximally taking out the clot really didn't help, but maybe there's some patients that we can target and some ways that we can do that. And so we built on that. Went into 2013, went into stitch 2, again, looking at those lobar patients. Okay, so not those deep hemorrhages near the center of the brains, but the more superficial ones. Again, multi-center, multi-country trial, a little bit more specific, those more intermediate grades, certain volumes. And it was early surgical evaluation within 12 hours of their randomization versus maximal medical therapy. Again, we dichotomized our outcome scale as a 1 to 6, but we either said that 1 to 2 is good, and everything else was not so good. And unfavorable outcomes and surgery versus medical management, not significantly different. So they didn't do worse. It didn't show that we were hurting people, but we didn't necessarily help them. But again, as we started to look more in subgroups, we said, there's a trend towards some improvement. So maybe there are some people that we're starting to help. But at this point, and everything we had learned, open surgery really wasn't helping us. So we as a society pivoted, as a practice pivoted and said, okay, are there ways where we don't have to do big open craniotomies, big open surgeries, that we can start to help these people? Because there were some patients that removing these clots were helping, but it wasn't as statistically enough. And so we started to do these more minimally invasive, and I'll show you what that looks like in just a second. But basically the concept is, if we disrupt less normal brain to get to these clots, can we make some improvement? So the way that we did that is we used image guidance. We put a very small hole through the bone in the skull. We put a catheter, small tube, in through the brain, and we left it there. And we instilled some clot-busting medication, recombinant TPA, every 8 hours for up to 9 doses. And then we said, okay, is using this ability to remove clot with just a small catheter help? Again, dichotomized these outcomes as to good and not good. Extended that definition of good a little bit, 0 to 3 versus 4 to 6 instead of 0 to 2. And what that showed, as you can see here, this is just volume of ICH reduction. So, in the TPA group versus a medical manager, we are goal of taking out clot, and we did accomplish that. So this is feasible. And then over here, we just looked at overall volumes. What that showed is, yes, we can do this. It is safe. It's technically possible. It's not going to hurt patients. And there was a trend towards good outcomes, but it wasn't powered enough. So as you can see, we want to say these MRSs that are on the lower end are better, and they were higher numbers in the treatment group. So now we started to get a little bit more confident and said, okay, maybe that we can have something that looks a little bit better. So as we continue to build on that, and focus on the efficacy of the technique now that we proved that it was safe. So again, spontaneous intracranial hemorrhages, again, these installation with these navigated catheters, until we got to a clot volume of 15 mLs or less, or we hit 72 hours. So there's a time window where we felt that it wasn't beneficial. And what we found is these MRS, these good outcomes, trended better at 180 days. Again, these are hard. They're not powered. They don't have enough patients, but there is a dose response effect. So the take-home message from MISTIE II, which we felt like we knew, but we had to prove, is that less blood, better outcomes. And for the neurosurgeons that participate in other types of neurosurgery, we know this as we're taking out tumors, as we're doing other surgeries, we try our best to minimize any blood exposed into the brain, and we really try to wash everything out and do as much as we can. This was kind of that data that showed that there is a dose response effect. And as we progressed a little bit further and said, okay, we have to achieve this less than 15 mLs in 506 adults, we did look at deep and lobar hemorrhages. Did this make a difference? Now, the hard part of interpreting this study is that it seemed well powered, it seemed well done, but the predefined reduction of target of less than 15 or equal to 15 mLs residual could not be reached in 41% of patients. So this is a significant number. So when we look at all of these outcomes in these MISTIE trials, in this MISTIE group, 40% didn't get to our end point, which means it's hard to interpret it. Now, if you break out the those that did achieve it, obviously it takes away your power, it decreases your numbers, but there was a very significant difference. And again, this is one of those where, you know, if we get to our target, if we get more blood out, it is safe, it is effective, and actually less blood does equal better outcomes. So this was very encouraging, but still significant technical challenges because it's very, very hard. You have very little control in how much blood you're actually able to evacuate. This is just a different way. Some people are chart people, some people are word people, just to look at in the MISTIE group, in the treatment group with the catheter, less likely for MRS6, very less likely for these worse outcomes for death, lower hazard ratio, better clot removal is better function. And again, the surgical target was not always obtained, but when it was, we had a significant improvement of what we called good outcomes, or those outcomes of 0 to 3. And also important is it is safe. We saw is increase, but we didn't see significant numbers in statistical world. How do we do this? What's the setup for this? So we use navigation, and this will tell you kind of how old it is, because this is not really what it looks like anymore. But what we do is we take an image from a patient, we use some surface tracing and some optical tracking with these kind of reflective markers that are both on the reference arm and at the patient, and we're able to map where they are in space relative to these reference arms. And that way, when we have a little pointer, we can see where we are exactly on the scan in real time. So you can navigate, this is a small peel away catheter, so we can navigate that catheter on this CT right into the clot, and you can see that here, okay? We can then take a smaller tube. This is, it's small, but it's a little bit bigger than what we'd want to leave. This is a ventriculostomy catheter. You know, most people that see these in the context of ventricular drains, and this is something that we can now leave on the long axis in the clot. And as you instill TPA, you know, as you get in the center of the clot and it is on both sides and exposed, you can get significant improvement. Very little control, but if it works, much, much better outcomes from these patients as you're able to remove those blood products and all those toxic effects that are downstream from that. So this was promising. We knew that if we got the blood out, we could do better, but we also knew that open surgery mitigate any of that improvement. And so how do we take something that's minimally invasive, but much more controlled to remove a significant amount of blood? So this is where some of these newer technologies come in. This is BrainPath, which was Nico, now Stryker. And BrainPath is this little clear tube right here. The blue is the obturator, so that's what you do to use to place it. And this is for transsulcal perivesicular surgery. We can do this surgery. This is not just exclusively by any means for hemorrhagic stroke. You can use these too for tumors in a minimally invasive way. You can use it to remove AVMs. You can do a lot of things. But there's some benefits, and we'll go through those, what they are in a minute. But this design was specifically used to go through a sulcus. So, you know, the brain has peaks and valleys in it. So using those valleys, and I'll explain why in a minute. But it also allows for something else that's really important, which is bimanual surgery. Surgeons like to use both hands. And so this tube, it comes in a couple of different sizes. It's big enough to get 2 instruments, 2 hands in there. The other proprietary instrument that we used was the Nico. This is just a device, has a little aperture, a little mouth on it that opens and closes and pulls in some of the clot that you can control with foot pedal. So you can have that open and close rapidly, or you can just leave it open and have it aspirate or suction. And it rotates. There is a little light source, as you can imagine, sometimes it's a little dark down that tube. And so using this actually significantly aided in what we were able to do in this minimally invasive way. So you guys just saw the other images of tractography. We can use some diffusion tractography sequences on the MRI and create these very beautiful maps. And what these maps are these are the highways, these are the pathways of how the brain communicates with each other. So, you know, how your vision obviously is in the front, but your visual cortex is all the way in the back. You know, we know that when we want to talk, our speech centers are in a certain location, but the motor centers are in others. And so these are really just the long communication pathways through significant structures of the brain. And these are very important because if the brain can't communicate with itself, then it can't accomplish the goal of what it wants to do. So when we go through normal brain through a gyrus, those are where those pathways are. And if we stay parallel to them through the sulcus, which is the emphasis of these MIP surgery, we are able to remain in parallel with these. Now, the things that we learn, shortest distance is not always the safest. You really want to look at these images. You want to understand what the least traumatic way is through these. And then the other really important part of this is this tubular design of this retractor that we see here, in that it completely evenly distributes the retraction forces. So if you were to have two blades or a single blade, and if you're in there and if you perform brain surgery, you know, the brain has some turgor, has some structure, is kind of a soft, a light gelatin jello, but you can cause injury in just retraction. You can actually dissect into the brain. Just with a single blade or with two blades where there's not really good ways to distribute that pressure. This completely evenly distributes it, so there's not a significant amount, and that allows for much safer surgery. Also, enhanced optics, the light source is very good. On the Myriad, you can also use exoscope, which provides you significant, or a classic microscope, and allows for excellent optics, bimanual two-hand surgery with the least amount of disturbance of brain tissue in the least important areas. So that's where we pull in ENRICH, the first and only positive trial. So these are inclusion, exclusion. Really, these are, you know, patients 18 to 80. You know, you want a volume where if you decrease it, you don't want too little, but you don't want too much. And 5 to 14, so those moderate to intermediate GCS. NIH stroke scale of greater than 5, so they have to be somewhat symptomatic, and then a pre-hospital independent functionality or a MRS 0 to 1. And you had to do surgery within 24 hours of your last known well. Exclusion, people who had bleeding disorders that couldn't corrected, people that had very good or very poor exams, significant amount of ventricular hemorrhage, because that was not something that we were going after in these, bleed in the thalamus or in the cerebellum, or secondary causes of hemorrhage like aneurysm, AVM, things like that, tumor. So when we started this trial, we looked at lobar, and they looked at lobar and interbasal ganglia. Again, we excluded other sites. And after about 175 patients, they did a subset analysis, and there was a significant difference in the we were seeing the outcomes in lobar versus interbasal ganglia. So the lobar are the more superficial, located in the main lobes, parietal, temporal, frontal, whereas the interbasal ganglia are those more deep structures, are a little harder to get to, so caudate, pallidum, capsule external, and the second half of the trial excluded those based off the preliminary data. What does the setup look like if we're going after one of these? So this is what was used in the trial. This is the setup that I'm very thankful to have. So Synaptive is an exoscope, which allows for very excellent optics and very good biomechanics for the surgeon. But it's, again, you have that tractography that is in real time in your neuronavigation. You pick your trajectory based off the least traumatic way into the clot. You have your retractor. There is a mounted optical array on it so that you can follow that in real time. And that's mounted on another arm that will hold everything still and then allows you to have two hands to work down this corridor. It looks quite narrow, but overall it does work. This is a small craniotomy, which actually I'll explain in a second, does have some benefit. You're really just going in between two gyri of the brain in order to get down to where that clot is, all the way down to the back of the clot. The benefit of this in a small craniotomy and not having a big opening is that it keeps the pressures in the brain high, which means when you develop some sort of escape hatch or release with this tube, it actually really does want to deliver the clot, because that is the path of least resistance. So you're actually, the design does utilize some of the pathology in pathophysiology to allow us to be as expedient as we can. Optics, we talked a little bit about. This is with the light source. As you can see, pretty significant difference, but you can very easily get two instruments in there. You can work, you have a great corridor. I've done these with a microscope and with an exoscope. Exoscope's a little easier because, again, body mechanic wise, you don't have to have your head as turned, so it's a little bit more of a comfortable surgery. But both something that are readily available in most hospitals that perform neurosurgery, and something that is very easy to use and provides adequate optics. So again, the ENRICH trial, 300 patients, 1-to-1 randomization between medical management and by ICH location. And again, we did talk about after that a subset of patients was removed from the anterior basal ganglia. Now, we use utility weighted MRS at 180 days. And what that means is that a good outcome gives you a little bit more benefit, and a bad outcome can give you less or even negative benefit. And so this is just showing you what those two arms looked like, and they were quite similar. And then really what we want to talk about is what did we see? What were the results? And so MIPS was favored at every step of looking at all these patients, discharge 30 days, 90 days, and 180 days versus medical management. So this was really, statistically significant. We no longer had trends towards, we no longer had only subset analysis. We have a first positive trial, which is a very big deal. When we're looking at these modified Rankin scales, again, this is the surgery group, and the lighter colors are bigger. And what that says is people did better. And we use this utility weighted, which means that even more than just this, the higher outcomes were significant. And it doesn't just give you good and bad outcomes. It gives you a lot more of a spectrum on where to really understand how patients did. So, we're learning how to do this, but the overall message is less blood in the brain is better. How you get there very much matters, and probably matters almost more than anything else. As we can see, the anterior basal ganglia, those deeper structures are still a challenge. We still haven't totally answered the best way to do that, but our techniques and our applications are expanding, and we're refining our procedures significantly. Stroke is becoming more and more of a surgical disease, which means we can make a big difference on these patients as neurosurgeons, and giving them not just life back, but quality of life and functionality back. I really love this quote. I think this is kind of how I see this going. We shall not cease from exploration. We are going to continue to push the boundaries. And while we are back from open craniotomy to minimally invasive catheter therapy, now back to craniotomies, it's different. We're in the same place for the first time. And I think that will continue on and on. So if anybody has any questions, I really want to thank you for your time. I know that's hard for everybody, and the opportunity to do this with the AHA.
Thank you so much, Dr. Binyamin. Really positive feedback in the chat as far as they really appreciate the graphics and the visuals for the non-surgeons in the audience. So thank you for that. Dr. Chen, I do have a question for you. So in your presentation, when you're speaking of the different research articles, what impact has withdrawal of care had on the outcomes of the ICH trials, in your view? You are on mute, Dr. Chen.
Okay, there we go.
There you go.
Yes, I think, with withdrawal of care, I think there was a prevailing nihilism early on. Okay, in the early after the first stitch trials, that why do anything if the outcomes are going to be bad, and so that did affect patients as far as the outcome. If you're not going to do anything, naturally they're going to have a poor outcome.
Thank you. This is for Dr. Binyamin. As far as the ENRICH trial, was resource utilization such as tracking length of stay and discharge disposition studied?
I know ICU length of stay was decreased. If you think about it, some of these hemorrhages kind of push on the ventricles and cause hydrocephalus, and yeah, so the resources needed for these patients were during their hospital stay, and their length of time in the ICU were less. I don't have those numbers. I didn't include them on here.
Oh, no worries. Thank you so much. General question to either of you. What % of stroke patients receive a surgical intervention of the ICH patient population, would you say?
It's hard to give that number because it's such a, this is new data, and obviously the setup is quite is not at every hospital. And so, we do it more frequently where I'm at, but that is not the case at every hospital because the data is so new that not everybody has adopted it. So I think my answer would be skewed versus somebody at a center, in a different part of the East Bay or even in a different part of California versus East Coast. So I don't know that I have a good answer for that.
Right. I think I would agree that I think that it varies. And even at my center, we have surgeons who are still doing decompressive hemicraniectomies, and a lot of it is getting the comfort, having comfort, because we all know how to do decompressive hemicraniectomies, and we know it works. Okay, that you can go in there, decompress it, and save the patient. So it's level of comfort. I think a lot of it is level of comfort, and I think that's the great thing about this series here is getting the knowledge base out there so people can pursue that level of comfort.
Absolutely. Well, thank you both. I know I all wish we all had more time for Q&A, and we will address any Q&A that is in the chat, and we'll have a way to access any Q&A on the back end. So we thank you both for your excellent presentations. And for our attendees, we're going to exit this session and move on to session 3. And so you can reach that link in your resource tab. So we will see you there. Thank you again.
Thank you.